Thank you for inviting me to this great symposium. I'm going to be, as Dr. Albain mentioned, talking about some issues related to prevention, survivorship, and symptom management. And as many of you have probably seen in the past, this graph of the number of cancer survivors in the U.S. Is pretty impressive. There are about 12 million cancer survivors, and about a quarter of them are survivors of breast cancer, about 3 million as of 2012. But that number is really increasing exponentially over time as we get better and better with our treatments. So thinking about how patients live their life after treatment has gained increasing recognition. And amongst survivors, there are a pattern of concerns that come up repeatedly, some of them being related to hair loss, pain, mostly pain related to treatments such as arthralgias from AIs, weight gain, neuropathy from chemotherapy, lymphedema, cardiac toxicity, fatigue, and then issues related to depression, physical limitations, cognitive changes, sexual dysfunction, menopausal-related symptoms, and then secondary cancers. And this year at San Antonio, there were presentations that focused on this first chunk of survivorship and some symptom-related issues that I'm going to talk about in a little bit more detail. So when you think about symptoms, it's important to recognize that there's a pathway, and there's a pathway between treatment and outcome, which has symptoms in the middle. And if a patient isn't going to get their treatment because they're afraid of symptoms, or if they stop getting their treatment early because of symptoms, then we can't achieve the optimal outcome, and it interferes with patients' quality of life. So if we want to maximize outcome, we really need to think seriously about the symptoms that patients get, how we can recognize it, and importantly, how we can manage it. That involves a multidisciplinary area of recognition and understanding, and I think we're starting to make some real improvements. So the first study I want to talk about is a study that got a lot of press, the Scalp Trial, which is very creatively named, Scalp Cooling Alopecia Prevention Trial by Dr. Nangia. And this is, just as a little bit of background, we know that chemotherapy is associated with, that's associated with alopecia is very distressing to patients. About 8 to 10% of patients avoid chemotherapy because of fear of hair loss. And there have been many reports over time in several countries, mostly European countries, that cooling the scalp with various different devices can result in prevention of alopecia. And these reports over time have resulted in some variable success. Now, the first study in the US that was reported by Dr. Rugo last year at San Antonio in December resulted in the FDA approval of Dignitana device for scalp cooling, and that was based on a prospective cohort study that was multi-center. But there had been no randomized trials of scalp cooling devices that were presented. So this year, a randomized trial was presented that randomized patients with breast cancer, stage 1 or 2, undergoing either neoadjuvant or adjuvant chemotherapy to either receiving the scalp cooling device during their treatment or to a control arm. And what was assessed was alopecia, quality of life, and toxicity in the device safety. So in terms of thinking about the results of the study, it's important to think about what grading is. And grade 0 hair loss is no hair loss, as shown in the first picture. Grade 1 hair loss is up to 50%. And the way it's determined is that there's no wig that's required. It's a little bit subjective. And then grade 2 is greater than 50%, requiring some type of wig or covering of the hair. So the result of this scalp cooling trial looked at success being grade 0 or 1 versus a failure, which is grade 2. And amongst the patients that had the cooling device, there was a 50% success rate. And amongst the patients that were randomized to the control arm, there was no success rate. It was 0, 100% failure by that definition. When you look at the subset of patients and you divide it down into the kinds of treatment that they got, we can look at the group that got taxanes, and amongst those, there was a higher success rate, approaching 53%, 65%. And amongst patients that got anthracycline-based therapy, the success rate was much lower at about 21%. So what are the downsides of this? Well, there are some side effects, but they're mostly controllable. About 10% of patients had headache, mostly on cycle 1 or 2 of their treatment. There was some nausea initially, about a 4% nausea rate, and some dizziness. Again, most of those during cycles 1 and 2 that dissipated by cycles 3 and 4. And then there was much smaller rates of other types of skin toxicities. Looking at patient-reported assessments of how they felt, most patients either felt that they were reasonably comfortable or very comfortable, with about 10 to 12% reporting they were uncomfortable or very uncomfortable during the treatments. However, they did quality of life assessments. And on the quality of life assessments that we typically see with these trials, there was no difference. However, we need to look at what those quality of life assessments really are. Many of these assessments were developed to look at patients getting experimental therapies with metastatic disease. So all of these patients were undergoing chemotherapy. So it may not be possible to differentiate one group of patients undergoing chemotherapy with this type of quality assessment measure compared to another group undergoing chemotherapy when the only difference is loss of hair. So it's not surprising that there was no difference in quality of life, even though we know that quality of life is affected by whether or not you lose your hair. Because if you don't ask the right questions, you might not get the right answers. So how does this compare to the study that was presented last year? So last year, multi-center prospective cohort study was presented by Dr. Rugo, looking at the DigniCap device. And they used the Dean score, which pretty much correlates with CTCAE. No hair loss is 0. 1 is anywhere from greater than 0 to 25%. Score of 2 is 25% to 50%. So less than 2 is what we would consider a success if you compare it to the Scalp trial. And then 3 and 4 would be considered a failure. And looking at what was presented, they reported a 70% success rate compared to our trial. Now, it's important to note that in this prospective study, everybody got a taxane. So when you look at the taxane arm of the Scalp trial, you can see that the success rates are remarkably similar between the two studies. And when you actually dig down and look at the number of patients or the percent of patients that had no hair loss at all, which is an easier thing to assess, it was 5% in both studies, remarkably similar. Now, they compared this to a control group, a group that did not want to be randomized. And in the control group, there was a 0% success rate. Again, very similar to what was found in the prospective study. So the next area I want to talk about is pain, and specifically pain that comes from aromatase inhibitors. This is a major issue, I think, for patients that take these hormonal therapies. We've heard all morning about whether or not patients should not only be taking them for 5 years, but 10 years. But one of the major limitations of taking these medications is the side effects, because many patients don't take it for the 5 years, and many more that take it for 5 years stop by the 10 years. So thinking of ways to control this side effect is critical if we want patients to stay on these treatments. So this is a study that looked at the drug Duloxetine, which is a serotonin norepinephrine reuptake inhibitor. It has been FDA approved for the treatment of multiple chronic pain disorders. And this study was motivated after a phase 2 open label study showed that patients with aromatase inhibitor-induced musculoskeletal symptoms had about a 60% improvement in pain. And this study was reported in the Journal of Cancer. You always have to question, when a study is non-randomized and non-placebo controlled, how much of this improvement is the result of the placebo effect. So as a result, this trial was conducted through SWOG, and it randomized patients that had at least a score of 4 out of 10 of baseline joint pain. The pain had to be worse since they started their aromatase inhibitor therapy, or new since they started their aromatase inhibitor therapy. And it was stratified by baseline pain score and prior taxane treatment. Because of duloxetine symptoms, there was a ramp up, 30 milligrams per week, then 60 milligrams for the 12 weeks, and then a 30 milligram taper compared to placebo, and the assessments were at 12 weeks and 24 weeks. So here are the results, or graphic representation of the results, and you can see that by 12 weeks there was a significant reduction in both groups. But there was more of a reduction in patients that took duloxetine compared to those that took placebo. So there was about a 0.82 difference that was statistically significant. That's on a scale of 1 to 10, roughly 10%. So significantly different, but how clinically meaningful that is, probably anything's meaningful when you look at compared to their baseline, which is a large reduction. So anything you give a patient that results in a substantial placebo effect probably has benefit. So this is actually the first drug trial that showed a benefit compared to placebo in reducing pain from this symptom. And they looked at a variety of different secondary endpoints, not just average pain. They looked at worse pain and how much pain interferes with your functional abilities, buttoning your buttons, brushing your hair, various different things. They looked at 2 validated questionnaires that have been designed for patients with rheumatologic disorders, one for the knees and hips and one for the hands, that not just looks at pain, but also looks at stiffness. Because I think when we talk to our patients, they say they can't get up out of bed every day because they're stiff. So pain doesn't always represent the whole syndrome, and they also saw significant reductions in both of those. But when they looked at depression, the one thing that the drug is actually FDA approved for, there was no difference in the group. So you may question, well, why would that be the case? Well, patients couldn't enter onto this study if they had depression. So since that was an exclusion criteria, it's not surprising that we didn't see a difference between those on placebo and those that were on the drug in such a short period of time. So one of the problems with giving a drug to control a side effect that comes from a drug is that they also cause side effects. And so the most frequent side effects that were associated with duloxetine were headache, fatigue, constipation, some other GI side effects, nausea. Look at the difference in nausea, 30% versus 6%. insomnia 14% versus 5%. So, this may be an effective treatment, but it also is worth noting that there are side effects of these medications. So a patient really has to be on the verge of not wanting to take their aromatase inhibitors anymore to consider taking a drug that causes more side effects. So in conclusion from the study, treatment with duloxetine did meet its primary endpoint of reducing pain compared to placebo. And there was improvement in pain in both arms. And I think we need to think about this when we look at any study for any side effect in terms of the design of the study, is that there's going to be a placebo effect if the study's done well. Duloxetine was relatively well tolerated and consistent with side effects that have been seen in other studies. But it's important to know that the improvements in overall quality of life and depression were pretty mild. So the third thing is that on my list was weight. And weight is important for a variety of different reasons. One, it might be important for prevention of cancer. Two, it might be important for preventing the cancer from coming back. And three, it can interfere with how somebody feels about themselves, because nobody likes to gain weight during treatment. So this is a study that looked at the WHI trial, which was a study of dietary modification using a low-fat diet. And the specific goal of this trial was to look at breast cancer incidence and mortality. And what was presented at San Antonio was a follow-up to the original study. The original study looked at 8 years. They now looked at 16 years of follow-up. This is a study that was done in close to 50,000 postmenopausal women. And it randomized patients to a dietary intervention versus information about diet given just for educational purposes. All of the patients in the study to be enrolled had to have a fat intake that encompassed about 32% of their caloric intake and needed to have normal mammograms. And the goal of the intervention was to reduce dietary fat intake, not necessarily weight. So as I said, the primary outcome was at 8 years. However, they linked the patients up to the National Death Index to get longer-term information on these patients. So the actual intervention from this trial was to reduce dietary fat to about 20%, increase vegetable and fruit servings per day with a target of 5, and increase grain servings a day with a target of 6. As I said before, weight loss was not the intention. And in the intervention group, there were 18 group sessions and then quarterly maintenance throughout the 8 years. So looking at the initial study at 8.5 years, there was no difference. The hazard ratio was 0.9 for new breast cancers, and no difference in terms of death for breast cancers. You can see the hazard ratio was 0.77, but the confidence intervals crossed 1. This was initially presented in 2006. What they did in this study was look at deaths after a diagnosis of breast cancer. So here, looking at the same subgroups, here's death from breast cancer. No statistical difference, although the p-value was 0.8. But when you looked at deaths after breast cancer, there was an intriguing reduction in the intervention group with a hazard ratio of 0.65, p-value of 0.02. So a reduction in deaths after breast cancer. And this is at the 8.5-year follow-up. When they then went and looked at longer-term follow-up, 16 years, there was no difference in deaths from breast cancer, just as before. And again, deaths after breast cancer remain statistically significant with a hazard ratio of 0.82. So why might this be the case? Well, one is that the intervention prior to breast cancer may have changed the biology of the breast cancer that people develop. And there's a suggestion that the breast cancers were different in that patients in the intervention group were more likely to have ER/PR positive breast cancers compared to in the control, where they're more likely to have ER positive, PR negative cancers that have a slightly worse prognosis. So one thought is that it changes the biology of the cancer. So to test this hypothesis, the group looked at what it would be like to control for both PR and weight, because weight was also different between the two groups. And when you control for baseline weight and subsequent weight change, you still see a significant difference in terms of death after breast cancer. But when you control for PR negativity, you eliminate that relationship, and you no longer see that relationship between PR status and breast cancer, the intervention and death from breast cancer after breast cancer diagnosis. So one may think that this may be the effect, and this is what the authors suggested, that PR status provided an explanation for about the 27% difference between the two groups. However, I think it's really important to think that other things may be affected that could affect overall survival, such as cardiovascular risk and cardiovascular death. And it's important to note that when this study looked at death following breast cancer, they looked at death from any cause. And lowering weight and being on a low-fat diet may have also influenced their likelihood of dying from non-breast cancer-related events. And this was not really suggested by the authors. So one possibility is that it changes the biology of the cancer, and one possibility is that it changes cardiovascular risk. So looking at a few other studies that looked at cardiovascular risk, this study was presented to get an idea of whether or not aromatase inhibitors affect the vasculature of patients that might contribute to increased cardiovascular events amongst patients on aromatase inhibitors. So when you look at the original studies of aromatase inhibitors, the ATAC trial, there was initially a black box warning because there were more ischemic cardiovascular events in the AR arm versus the tamoxifen arm, 17% versus 10%. That black box warning was subsequently removed when the 10-year results showed no difference between the two groups. And that's shown in the first figure. You can see that events of cardiovascular disease, cerebrovascular events, were remarkably similar between the two groups. What has been shown is that aromatase inhibitors can affect your lipid levels. And this is looking at the other chart, results from MA17, where they looked at the percentage of patients that exceeded lipid thresholds. And you could see that they broke it down by the number of risk factors that patients had for cardiovascular disease. And the higher the number of risk factors, the more likely they were to have a higher threshold of exceeding the lipid level. Close to 66% of patients met that. And very few patients had low HDLs. So this study looked at a device to measure vascular function that's typically been used in the cardiovascular research arena as an independent risk factor for having a cardiovascular event, above and beyond what you might expect from a Framingham risk score. And it basically is a way of measuring vascular flow. So what the study did was, it was a cross-sectional case control study looking at 25 postmenopausal women and compared it to 36 postmenopausal women that had curative intent breast cancer and were on an aromatase inhibitor. None of the subjects could have any major cardiovascular risk factor to be included, including hypertension, hyperlipidemia, or tobacco smoking. And they underwent this analysis, this pulse wave analysis, to look at large artery elasticity, small artery elasticity, and the ratio between them, which is the most predictive marker. Now, what they found was that there was some difference in large artery elasticity, but it was not significant. Some difference in small artery approaching significance, but the ratio that is the most significant predictor of outcome was statistically significantly different between the AI group and the control group. So they concluded that women on AIs may have a reduction in endothelial function, and that may be an explanation for worse cardiovascular outcomes, although we don't really have evidence that they have worse cardiovascular outcomes. And that prospective studies really need to understand whether or not it's the aromatase inhibitors, maybe whether or not it's lipid levels, and really thinking about what these increased risks are from. Because when we look at the control group in this patient population versus the patients on aromatase inhibitors was not the only difference between the two groups. These patients with breast cancer may have had chemotherapy and may not have been followed the same way in terms of other factors that could affect their vascular function. So we don't know 100% the cause of the difference between the two. So again, getting to the issue of whether or not there really is or isn't an increased risk of poor cardiovascular outcomes in patients on AIs. This is a study that was presented by Jennifer Leigabel several years ago at San Antonio and then subsequently published, looking at patients that were on breast cancer that were not on hormonal therapy, on an aromatase inhibitor versus tamoxifen. And there was really no difference between the three in terms of risk of myocardial infarction, risk of ischemic stroke, risk of hip fractures, or risk of, the only difference was with regard to risk of hip fractures. So as you might expect with the aromatase inhibitors. So this study suggested that there really is not a worsening of aromatase inhibitors compared to those patients that aren't on any treatment at all. Prior studies looked at tamoxifen. So in this year in San Antonio, another group presented a poster in a discussion session that looked at this same issue using SEER Medicare. And what they did was they looked, now that Medicare data is linked to the Part D, they could look at aromatase inhibitors and tamoxifen and control for some of the other comorbid conditions that aren't typically controlled in clinical trials. Not only did they find a very low rate of having a myocardial infarction in a short period of time on this study, they really found no difference between aromatase inhibitors and tamoxifen with a hazard ratio of 0.01. So that confirms the other studies that had been done. So finally, the last thing I wanted to talk very, very briefly about was chemotherapy-induced peripheral neuropathy, which we know is a dose-limiting toxicity of many of the drugs that we use, and it can limit the drug and duration of treatment that we give. We recently published ASCO consensus statement and guidelines, and we reviewed all the randomized trials, 48 randomized trials conducted, 42 in prevention, 6 in treatment. Most of the interventions were based on anecdote, maybe some evidence in diabetes and some preclinical data. And for the prevention, which most of the studies fell into, there was only evidence of harm. So 2 studies showed evidence that either calcium, magnesium, or acetyl L-carnitine increased the rates of peripheral neuropathy. 1 study showed some benefit in treatment of painful neuropathy, duloxetine, but no other studies showed any real benefit. And there were close to no studies on non-pharmacologic treatments for either the treatment or prevention. This year, there was 1 poster that looked at compression therapy in patients using surgical compression gloves, in patients getting albumin-bound paclitaxel, and subsequently getting peripheral neuropathy. And they found a statistically significant improvement in both sensory and motor neuropathy from this intervention. It should be noted that there was no change in the control group, and the control group was non-blinded. So you always have to, looking back at the other studies that have been done, you always have to question when the control group is non-blinded. This is a study that was presented earlier. It's a little fuzzy here, so I don't need to mention it in detail, but this is a crossover study looking at usual care versus acupuncture. And again, you can see a reduction in peripheral neuropathy in the group that got acupuncture compared to usual care, and then diminished difference between the groups when acupuncture was stopped, and then an improvement in the other arm. Again, the control arm for this study was usual care, so patients knew they were getting acupuncture versus not. Now, it's encouraging to see the difference in the CIPN-20, which is a validated score at 6 weeks, but I think we really need to think about how we do these studies in terms of not having a no treatment control. And just as a comparison, this is a study that we did looking at electroacupuncture versus sham electroacupuncture. Nobody had had acupuncture, and I don't know if anybody of you know these devices, but you put in the needles and then you attach wires to this other device that gives pulses of electricity. And so there was a pretty elaborate sham that was set up. Nonetheless, there was no difference in the group, and along with the theme of studies I'm involved in, there was a worsening of neuropathy in the patients that were in the true electrical acupuncture group when they stopped the intervention. So I don't know why that was the case, but that was the case. So the take-home points from the studies I reviewed one study looking at scalp cooling, I would say that it does appear to prevent hair loss, especially with taxane-based regimens in about 50% of patients. Duloxetine is an option for patients with significant pain from their aromatase inhibitors, but probably only patients that are willing to accept the side effects because it might mean that they're coming off their treatment. Low-fat diet prior to a breast cancer diagnosis appears to reduce the time to death after breast cancer diagnosis. We don't really know the reasons for that. There may be some vascular changes that result from aromatase inhibitors. I think more work needs to be done understanding on ways to reduce cardiovascular events in cancer survivors, because they're more likely to die of cardiovascular disease than of their breast cancer. And again, more work needs to be done for CIPN, because this is a very important side effect of many of our treatments. But there does seem to be a suggestion that local therapies may be beneficial in improving symptoms.